talk about the macrocirculation and the ways to monitor it. First, I would like to disclose I've received, of our research group, received research grant from Transonic Systems and Pulsion Medical Systems. This is what you've seen already in the former presentation, and if you measure cardiac output or monitor the macrocirculation, there are several ways to measure it. You can measure right ventricle output, left ventricle output, aortic flow, ascending aorta, descending aorta, SVC flow. And what we're looking at, and we already addressed this issue, is we want to prefer a neonatal shock. We're aiming at a optimal oxygen delivery in relation to the oxygen demand. This is what I've shown already. This is what we can measure. This is what we can measure. We can also measure PO2, but that can be neglected regarding the total oxygen concentration on the arterial side. So if we would be able to measure cardiac output, we can determine what the oxygen delivery is. And I'm focusing on the macrocirculation, but if you look at the oxygen balance, it's not only on the global level, you should also look at the oxygen balance in the microcirculation, or into more detail at a cellular level, and going even more into detail at the mitochondrial level. But for this presentation, I will focus on the macrocirculation. And as already stated, a good macrocirculation, a good cardiac output is not a guarantee for an adequate organ perfusion. Why should we measure cardiac output? Well, we assume that if we measure cardiac output, we monitor the macrocirculation, it would be beneficial for the patient and it might reduce morbidity and mortality. We know that the low cardiac output is associated with an increased mortality in children. And also in older children, it has been shown that any delay in the diagnostic process of a neonatal or pediatric septic shock, it will increase mortality. And focusing on preterm infants, we know that a low systemic blood flow is associated with an increased risk in intracranial hemorrhages, in a reduced urine output and a subsequent hyperkalemia, increased mortality, impaired neurodevelopmental outcome, and compromised EEG activity. And as Anko Top already mentioned, there's a very poor agreement between a clinically estimated cardiac output and objectively measured cardiac output. And that is very nice shown in a study by Shane Tibby from London. He measured cardiac output on the PICU, so older children, with an objective method. It's a transpulmonary thermodilution, the PICO method. And they asked the clinicians, what's the cardiac index in this patient, and blinded the cardiac output measurement objectively was blinded for the clinicians. They could use everything they wanted, from blood pressure, heart rate, urine output, blood gas analysis, lactate, central venous oxygen saturation, etc. And what is shown, they were asked to give an exact number of the estimated cardiac output, and as you can see, it was not that good, but they were also asked to categorize it in, do you think cardiac output is low, low to normal, high to normal, or high? And even that, with a kappa of 0.09, there's a very poor agreement between the clinician's estimate and the measured cardiac index. And to show, in the patients definitely in shock, a cardiac index lower than 3.0 liter per minute per square meter, only a quarter of the patients in deep shock were recognized clinically, so 75% were missed. There are several techniques of cardiac output measurement in critically ill patients, but it remains very complicated in newborns due to size restraints. Here you can see a use of a GL probe on the forearm of a preterm baby, and as you see, we can't use that. And here, there's a Swan-Ganz catheter draped around the preterm infant. So the size restraints are important. Also the presence of shunts. Most of the technologies used to measure cardiac output can't be used in the presence of a shunt. Another point is indicator toxicity. There's a method that uses lithium, the lithium dilution technology. But I'm not that keen to inject lithium into a preterm baby, so that's not possible. Another method, the CO2 rebreathing technology, that uses change in arterial carbon dioxide pressure, and also that's not what we want in a preterm baby with respect to cerebral circulation. So there are many technologies, and which device to choose? Well, looking at what are the ideal characteristics, it should be validated against a gold standard method. It should be accurate along the entire spectrum of gestational age and birth weight, continuous measurements in absolute numbers, reliable, practical, etc., etc. But to be honest, this is the way to utopia. There's no such thing as a method with all the ideal characteristics. Let's pay attention to accuracy and precision, because I think that's very important. When you want to look at a new method of cardiac output measurement, you have to validate it against a gold standard, a true method of cardiac output measurement. And on the x-axis there is the accuracy, which says how close are you to bullseye, and on the y-axis is the precision, how close to each other are every repeated measurements. And as you can see, this is the worst case, a low accuracy, a low precision. It's at random, is you don't hit the real target. This is interesting. It has a low accuracy because it's not bullseye at all. But you see, the repeated measurements are very close to each other. So you can maybe use it with an offset. There's a bias, but if you correct for this, maybe it's usable. On this side, you get a high accuracy because when you average all these measurements, it will be bullseyes, but the precision is low if you use lower number of measurements. This is the ideal situation when every measurement hits bullseye. There are several methods of cardiac output measurements. The Fick principle, indicator dilution technologies, Doppler ultrasound, arterial pulse contour analysis, thoracic electrical impedance, and others such as MRI or three-dimensional echocardiography. And I'm going to focus on these 5 methods of cardiac output measurements, since these have been validated, been researched in the neonatal population. First, the transthoracic echocardiography. We all know it. We use it more, we use it increasingly on the neonatal intensive care unit. We call it functional echocardiography, targeted neonatal echocardiography, and my colleague Shaib Nori will discuss more about that. And what we should know is that when we measure cardiac output, whether you measure left ventricle output, right ventricle output, SVC flow or aortic flow, we should know what are we actually measuring. So in case of a left ventricle output, you measure systemic blood flow plus the ductal flow when there's presence of a left to right shunt through the ductus arteriosus. The right ventricle output is in fact the systemic blood flow increased if there is an atrial shunt from left to right. That's why the SVC flow was introduced, because the SVC flow is not influenced by these fetal channel flow, but you don't measure all cardiac input, but only the cardiac input from the upper body. When you measure aortic flow in the ascending aorta, you should notice that you're measuring systemic blood flow minus the coronary blood flow, which can be a quite high amount, about 10 to 20% of total cardiac output. And when you measure descending aortic flow, it's a systemic blood flow minus the upper body blood flow. It's always very difficult, what is cardiac output? I think what we can say, what has been in the system, so the systemic venous return, I think that is the true systemic blood flow. That is QS. And the pulmonary venous return is QP, is the pulmonary blood flow. Chu and colleagues in 2003 wrote a review about the Doppler cardiac output measurements in children, and they focused on repeatability, bias, precision, etc. And they compared echocardiographic cardiac output measurements with other forms of cardiac output measurements, such as dilution, Fick method, and thermodilution technologies. Bias was not that much, but there's a precision of plus minus 30% with these numbers of intra and inter-observer repeatability. What does that mean? There's a large variation. Why? I think the angle of inclination is of importance. It has been shown that an error of 5 to 10 degrees in the intercept will lead to an error of about 20% in blood flow measurements. And when you look at difficulty in the velocity time integral assessment and error in the cross-sectional area that is needed for this type of cardiac output measurements, I took a preterm infant, heart rate for example, 130 beats per minute, VTI, which is the P50 of 9.3 centimeters. Only a change in diameter, an error of 0.5 millimeters, will cause a change in flow measurement of 23%. I think Doppler-derived cardiac output measurements are more useful to measure changes in the situation instead of assessment at that time for the absolute value. It can give you an indication, is flow high, is it low, but it's very difficult to accurately determine cardiac output. Brings us to the TransCutaneous Doppler, also known as the ASCAM, and that is the assessment of cardiac output with a probe positioned on the thorax, aiming, so it's not with in comparison with transthoracic echocardiography, where you can see where the pulmonary artery is and exactly measure at the right spot, but this is aiming and looking for the best curve, the best VTI on the screen. And you don't measure the aortic valve, the cross-sectional area, you don't measure the pulmonary valve. It's derived from an algorithm, and so you should expect it's not as accurate. And that has been seen in a meta-analysis of the accuracy and the precision of the ASCAM, and it showed that the error percentage is about over 40%. And what is clinically accepted in cardiac output measurement is when the error percentage is below 30%. But then it has to be validated against a good reference method, a good gold standard reference method. And that's not always the case in all the studies. Then that brings us to the thoracic electrical impedance, and that's very, very interesting, because this is the only true non-invasive technology of cardiac output monitoring. And it was already published in 1966, and it was developed by NASA to analyze cardiac output function under zero gravity. And it is known that the electric conductivity of blood is higher than that of muscle, fat, and air. And when you apply a high frequency, low magnitude current across the chest, you can measure that through the electrodes, and it distributes mainly to the blood. And you will get pulsatile changes in the thoracic electrical impedance, and that corresponds with the pulsatile changes in thoracic blood volume. And that can be used to get an impression of cardiac output. And from a study from our colleague Shahab Nouri, they looked at the electrical velocimetry and compared that to transthoracic echocardiography, and what they show is an error percentage of just about 30%, but keep in mind it is in relation to the transthoracic echocardiography. But I think this is very interesting because it would be very nice in a non-invasive way to measure cardiac output if that's possible. Brings me to the transpulmonary ultrasound dilution. When you've got an unknown volume but with a known concentration and you add a known concentration of dye and of a known amount of dye, you will get a new concentration and you can calculate the volume out of this. So this is used in the indicator dilution technology. First, you inject a known amount of indicator into the circulation. This is mixed and diluted in the heart, and you can detect it downstream on the arterial side, and you record the concentration of the indicator over time. And with the so-called Stewart-Hamilton equation, you can calculate cardiac output. And the cardiac output is inversely proportional to the area under the dilution curve. And as you see over here, this is a normal dilution curve, and when you've got a very low cardiac output, you have a higher, a broader, more broad curve, dilution curve. And the indicators that have been used or are used are indocyanine green, cold solution, so really ice cold solution, the thermodilution. In the adults, we know that from the pulmonary artery thermodilution, the Swan-Ganz catheter. We know it from the PICO, the transpulmonary thermodilution. It's quite interesting, but you have to use a dedicated arterial catheter, and unfortunately, we can't use that in a newborn infant. And one of the newest possibilities is to use isotonic saline in the transpulmonary ultrasound dilution, which I'm going to explain right away. If one sends ultrasound through blood, the ultrasound velocity is dependent from the total blood protein, the temperature, and the average ion concentration in the plasma. And through blood, ultrasound velocity is in this range, and through normal saline, it's decreased to this velocity. So that can be used in transpulmonary ultrasound dilution. First, I will give you an example. What we do is we inject the indicator with this, which is normal saline on body temperature, so not ice cold. On the venous side, it is detected by the venous sensor. It goes through the body, through the baby, so right heart, lungs, left heart, and is detected on the arterial side. And because of the saline, you get a decrease in ultrasound velocity, and in fact you get an ultrasound dilution curve, and the area under the curve represents cardiac output, and with the Stewart-Hamilton equation one can calculate cardiac output. But you have to place sensors on the venous side and on the arterial sides, and we don't want to operate the babies, we want to do that in another way. So what it means is that we connect any central venous catheter to an extracorporeal loop and connect it again to an arterial catheter. No dedicated catheter. It can be used with umbilical catheters, it can be used with peripheral arterial catheters, or with other central venous catheters, no dedicated. It's a disposable AV loop with a priming volume between 0.9 and 2.4 milliliters. The sensors are put on the extracorporeal loop. In that way, you can detect the change in ultrasound velocity. There's a small pump which serves for a constant flow throughout the measurements, and note that only during cardiac output measurements, during 6 minutes, there's flow through the extracorporeal circuit. There's a saline fluid warmer to put it on a patient temperature. And to be honest, the first time I heard of this method, I thought the one that presented it to me was crazy. Who is going to connect an arterial line with a venous line and is going to have blood flow through that extracorporeal circuit? But when he told me that it was possible to measure cardiac output without any adverse effects in rats, in rabbits, I got interested and I tested it in the animal lab. I tested the effect on cerebral circulation, on systemic circulation, and I didn't see any adverse effects. The changes that I see is within the normal range. So with that, I thought it can be applied in the clinical situation. I validated it in the animal lab in a lamb model, and what I did is I made a Bland-Altman plot. And with the Bland-Altman plot, that's the way to validate a new method against a gold standard reference method. The reference method is a transit time flow probe around the pulmonary artery. We took the pulmonary artery because that's the real cardiac output. If you take the ascending aorta, you will miss coronary blood flow. And I measured cardiac output with the ultrasound dilution using 0.5 ml per kilo of saline as an indicator and 0.1. And as you can see, there's no difference between those. And we got an acceptable bias and precision. And what's interesting to neonatologists is that the injection volume of 0.5 ml per kilo is as accurate as 1 ml per kilo. So, well, we prefer to inject as low volume as possible. But all our patients, the preterm patients, you should take in consideration that there is a patent duct with a left to right shunt. Is this method also applicable, reliable in the presence of a shunt? So in the animal lab, we constructed an artificial ductus arteriosus with a Gore-Tex shunt between the pulmonary artery and the descending aorta, and we measured blood flow. And what we see is that it's also feasible in lambs with a significant left to right shunt, up to a QP-QS ratio of 2.5. So this method is applicable in a shunt circulation. It is able to detect the shunt. The machine will tell you that there is a left to right shunt. And we looked at the predictive value of these messages. And what the results are, we have positive predictive value of 86%, a negative predictive value of 97%. And to translate that to the clinical practice, suppose we got a pretest probability of adductors in the preterm infants in between 20 to 60%. We all know the incidence, it determines what's the definition, etc. The positive test will tell you that the post-test probability is about 60 to 90%, and the negative test will tell you that it's only 0.5 to 4% possibility of a patent duct with a left to right shunt. What about the quantification? You can get a QP-QS ratio with this type of cardiac output monitoring, but we tested that also in this lamb model, and it is not as good as we would like it to be. It is not accurate enough, and we think there must be an update on the used algorithm, and we'll wait for that. But at this moment, the quantification is not as accurate as we would like it to be. We treat babies with lung injury, RDS, and we hypothesized that with a lung injury, especially with a heterogeneous lung injury, that there can be difference in the transit time of the indicator, the saline, through the lungs, with some saline passing very quickly and some saline passing very slowly. So that differentiated transit time for the indicator, will it have an implication for the accuracy of this ultrasound dilution method? And in a lamb model, we used surfactant washout, and we made a RDS, and we evaluated this method, and also we saw that the accuracy and precision is in the acceptable range, so we concluded that ultrasound dilution technology is reliable in the presence of a moderate to severe RDS. That brings me to the arterial pulse contour analysis. This is also very interesting because we all know that we have the arterial pulse contour, and it was already postulated by Frank in 1899 that there must be a relation between cardiac output and the arterial pressure waveform. And the arterial pulse contour analysis, APCA, it measures stroke volume on a B2B basis from that pressure waveform. And there has been several algorithms being developed to estimate the stroke volume from this arterial blood pressure. So if you got an arterial line, that would be very interesting, that from that arterial blood pressure you can determine what the stroke volume is. Even more interesting is when you can have a non-invasive blood pressure curve, like NextFin or something like that, and then apply an algorithm, then you could non-invasively measure cardiac output. Unfortunately, it's very, very difficult to have a good algorithm. There are algorithms, but only applicable to adult patients. And a recent review showed that they are not very accurate. Why is that? The arterial pressure waveform is the resultant of an initial pressure wave and a reflected pressure wave. And the first initial pressure wave is proportional to stroke volume. And this is coming back from the peripheral vessels. And you can expect that the arterial pressure wave will have a high variation on a different physiologic and pathophysiologic condition. And also, it's very important where you measure the arterial pressure waveform, because where you measure, the more distal you will get another waveform. There's no linear relationship between blood pressure and flow in the aorta, and that's due to the aortic impedance, and that's influenced by compliance, the resistance, and inductance, the inertia of the blood flow. So it's very complicated to have arterial pulse contour analysis and measure cardiac output with that. But maybe we can use it together with other methods of cardiac output measurements. Like in the PICO, the co-status, the ultrasound dilution, and in the LITCO, you can measure cardiac output with the invasive way and calibrate arterial pulse contour analysis. So you measure cardiac output in an accurate invasive way and use that to calibrate your arterial pulse contour analysis. And in the meantime, you will use the pulse contour analysis to see the trend of cardiac output. And when there's a difference in cardiac output, 10 or 15% or whatever you would like to define, you can say, okay, that's the moment I have to do another measurement with the invasive cardiac output measurement technology. Okay, then we can measure cardiac output, but how much should cardiac output be? Well, it depends, of course, where you measure cardiac output. And I've looked at several normal values that's been published in the literature, and there are some from right ventricular output, left ventricular output, SVC flow, and you know all that there is a development during the increase in postnatal age. These are the normal values, but when do we have to intervene? That's always very difficult. These are the normal values that's been published by Alan Gross and his group with measuring cardiac output using a cardiac MRI in relatively stable preterm and term infants. And Kurt Lewal has suggested a classification in reference values that central blood flow is normal between 150 and 600 ml per kilo per minute for the right and the left ventricular output. 45 to 150 ml per kilo per minute for the SVC flow. It's low below 150 for the ventricular output and below 45 for the SVC flow, and it's pathologic low when it's below 120 for the output ventricular and below 40 for the SVC flow. On the other side, it's high when it's above 600 and above 150. But I don't know whether these are the right normal values. Can we apply this to all patients? To give an example, I'm just started a study and measuring cardiac output on the NICU with the ultrasound dilution, and it was in a very stable, uncomplicated patient with a congenital diaphragmatic hernia, no signs of shock with everything we've noticed. No, there was an oxygen need of 21%, low ventilator settings, good urine output, good blood gas analysis, no suspicion at all. But there was a low cardiac output when I take into account these reference values. So should we adjust the reference values, or is it a problem in the baby that we don't know yet? So I'm not sure. We have to study that and analyze that in more detail. This I already told. Functional echocardiography, that is what I said, what I meant. When we determine cardiac output, whether you take right ventricle output, left ventricle output, SVC flow, still you need functional echocardiography. I think you have to be able to interpret the number you get from the cardiac output in the perspective of the actual circuit. Is there a shunt? Is there a atrial shunt? Is there a ductal shunt? And that is why I think you should have functional echocardiography. It's also necessary, whatever technology you use for cardiac output measurement. Why not measure cardiac output? Well, there are some concerns from the adult intensive care. They looked at clinicians, they showed them parameters derived from Swan-Ganz catheter studies, they showed them parameters for cardiac output, wedge pressure, etc. And the majority wasn't able to interpret the variables in a correct way. So it's very nice if you can measure cardiac output, but if there's a wrong interpretation, you don't do anything good. And to be honest, at this moment, there's still limited evidence that cardiac output measurement, cardiac output monitoring is beneficial for the patient by reducing mortality and morbidity. What we see in pediatrics and in adult intensive care, if you have the early goal-directed therapy with a goal of the venous oxygen saturation above 70%, to have a cardiac index above, I think, 5 liters per minute per square meter, then they saw a better survival. I don't know whether that's also applicable with other reference values for the neonatal population. And what is said, I think this is very wise, no cardiac output monitoring device can change patient outcome unless it's coupled with an intervention that by itself has been associated with improved patient outcome. No monitoring device, no matter how simple or sophisticated, will improve the patient-centered outcomes unless coupled with a treatment that itself improves outcome. That brings me to the conclusions. Cardiac output monitoring in preterm infants remains very challenging despite the availability of many technologies. I think it's very important to validate any new designed systems and evaluate it for accuracy, precision, and safety. It might be beneficial to measure cardiac output in the neonatal population. It might reduce morbidity and mortality, but that still has to be proven. Anyone who uses any method of cardiac output monitoring, I think, is obliged to understand the basic principles of the applied technologies and the advantage and the limitation in order to prevent any error in hemodynamic management. Also, pay attention to accuracy and precision. A non-invasive cardiac output monitoring with a low accuracy and precision is dangerous. I think that functional echocardiography is still essential for a correct interpretation of cardiac output values, irrespective of the method used. Already mentioned more often this morning, a normal value of cardiac output does not imply an adequate perfusion in all tissues. It will only provide information on the global flow. Advanced hemodynamic monitoring will not improve outcome. It's the correct interpretation of the variables and the resultant therapeutic management that might improve outcome. Thank you.